Hello and welcome to this OncLive peer exchange, optimizing outcomes in tenosynovial giant cell tumors. I'm Dr. Shreyas Kumar Patel from MD Anderson Cancer Center. Joining me today in this virtual discussion are my colleagues, Dr. John Abraham from Rothman Orthopedic Institute, Dr. Gina D'Amato from Sylvester Comprehensive Cancer Center, Dr. Robert Mackey from Penn Medicine, and Dr. Taewon Kim from Cooper University Healthcare. Today, we're going to discuss a number of topics pertaining to the diagnosis and treatment of tenosynovial giant cell tumors. Let's get started on our first topics. We have divided this into three different subsets. We're going to start off with the generic epidemiology diagnosis and differential diagnosis of tenosynovial giant cell tumors. I'm going to ask one of my colleagues, Dr. Abraham, to start us off and provide us an overview of tenosynovial giant cell tumor and the disease state in general. John?
Thanks, Dr. Patel, and it's great to be here and happy to participate. Tenosynovial giant cell tumor is now recognized as sort of one entity, but previously we didn't really know as orthopedic surgeons the difference between tenosynovial giant cell tumor when it happened in a tendon sheath, like in the upper extremity or hand and forearm that we see, or in large joints like the hip and knee, predominantly the knee. So now we are starting to recognize that this is one entity and happens in any synovial lined area, including large joints, small joints, and tendon sheath. So thinking about the incidence, some of that information over time is becoming clearer because the original studies on incidence were just looking at what we used to call PVNS, which we now know as TGCT of a large joint. And so it is a rare disease, but probably less rare than we originally thought. The numbers in particular for overall incidence of TGCT is probably somewhere in the range of about 30 per million person years. And that includes the hand and upper extremity tenosynovial type, and then including also the localized and diffuse types in joints. And the most destructive type that we see really is the diffuse type in larger joints, and that is probably on the order of 4 to 8 per million person years. So the point being that it is rare, but it's probably less rare than we originally thought. When we see these kind of patients, there is probably a slight female predominance. Most of the studies do show a slight female predominance. And in terms of age group, we see the kind of full spectrum of ages. And that may be due to the fact that there's sort of a variable presentation. So, if you have mild disease, you may not come to medical attention until later on in the course of the disease. So the diffuse disease in the large joints really does seem to present in sort of younger age groups like 20 to 40 years of age, because that diffuse disease does cause quite a bit of disability, and that younger age group really feels that disability. If looking at studies in terms of the overall age group, the most common presentation is about the 40 to 60-year-old age group. So it really does span pretty wide ages. In terms of what we see when patients come in with this kind of a problem, really what we're seeing is akin to a synovitis or similar to a synovitis. So you get a very inflamed and thickened synovium. And so there are a number of conditions that can cause that. And we usually have to think through which of those conditions could be affecting this one particular patient. And things that we see that cause a synovitis include infections, and that includes things like Lyme disease. We see synovial disorders like rheumatoid arthritis or lupus, and then tumorous conditions like TGCT. So we have to keep those things in mind when we see these kind of patients and try to figure out which of those things could be affecting the patient. One distinguishing factor is that TGCT really most commonly will only affect one area. So one joint, one large joint. It doesn't mean it can't occur in more than one place, but in general, we generally see it in one place. The common thing that we think of when we think of the symptoms are we have a buzzword in orthopedics that we use. We call it recurrent atraumatic hemarthroses. So hemarthrosis is bleeding into a joint, and it can happen with trauma, but it can also happen atraumatically. And with TGCT, we often see the knee or whatever joint is affected, sort of the patient say, my knee just blew up, which means it got sudden and severe swelling. And usually that swelling is from blood. And that blood comes from the thickened synovium and the very friable tissue of the synovium, which tends to dump large quantities of blood into the joint and then give the symptoms. The blood is also very irritating to the remainder of the synovium and the rest of the joint. And so we get secondary kind of symptoms from that also. What's interesting is that in my own clinical practice, I can say that I've seen some patients with diffuse disease who have relatively mild symptoms, but in general, diffuse disease gives pretty severe symptoms. But then the localized form can be interesting because I have seen patients who have small localized lesion, but have, the classic kind of recurrent atraumatic hemarthroses and have severe pain and disability and stiffness, even from one small lesion. So it's hard to predict based on what we see in terms of how much disease is in the joint, what the symptoms will be. And so many times for those patients, even with a small localized lesion, if I've removed that lesion, their symptoms can get better.
Wonderful. So thanks for getting us off to a great start, John. I think as all of us who have some experience with this disease realize that the patient's journey probably starts with joint symptoms like you outlined, and I'm sure that they sort of go to their PCP for a little while, non-steroidal trials for arthritis-related symptom control and stuff, and eventually they would make it to the community orthopedic surgeon and eventually to an orthopedic surgical oncologist, I guess, right? Does that make sense? Yeah, go ahead. Go ahead.
Well, I was just mentioning that's correct. And I think that's probably generally how the flow will come. And I think that's actually appropriate also because we don't want to necessarily do $1 million workup on every patient that comes in with knee pain. So it makes sense to treat for the more common things and treat for things like arthritis or injuries. And then if the patient fails to improve, then, imaging is indicated, whether you're suspicious of PBNS or TGCT rather, or some other condition.
Fair enough.